Bueno, vamos a empezar. Salamanca, ¿me oís? Soy Paco, Salamanca.
Buenas tardes, Paco, te oímos perfectamente.
Gracias por conectaros. Buenas tardes. Oviedo.
Sí, os oímos bien.
Muchísimas gracias por conectaros. Buenas tardes. ¿Nos oís bien?
Sí, perfectamente.
Nosotros también. Bueno, pues vamos a empezar el meeting. Good afternoon, everyone. Many thanks for the connection. Particularly happy to be connected with Salamanca and also with Oviedo. Many thanks for the connection and welcome to the meeting. Salamanca is an old friend in this kind of adventures, but Oviedo is new, and we are very, very happy to be connected with Oviedo. Many thanks, and welcome to the meeting with cardiovascular experts. We organize normally one time every month this meeting. During the last 12 years, this year we have only one meeting because of different circumstances, economy and others, but this is very special. And it's very special because we will focus the meeting in a serious problem, and one of the challenges of modern cardiovascular medicine, which is the connection between our specialty, the heart, the cardiovascular system, and the use of drugs and radiotherapy for the treatment of patients with cancer. This is a real challenge in which we have spent a lot of time during years doing as better as possible in a normal way, in the way in which the hospital normally works. But 3 years ago, we realized that it was not enough. We decided to organize this combination of efforts required by the problem, the connection between cancer and cardiovascular diseases, and started the program that we have today with the leadership of amount of excellent people from the Department of Cardiology, Eduardo, and people incredible from radiotherapy and oncology and hematology. So we create a new structure, and we decided to learn, and among the key people in the world, decided to be connected with Jörg Hermann, and invited him to teach us how to organize and how to proceed in this difficult adventure. Firstly, by continuous connection with him through the different ways, and secondly, by an extraordinary meeting we had in Seville during the last annual Congress of the Spanish Society of Cardiology. And there we decided to have Jörg here in our house to take advantage of his enormous knowledge and experience in this discipline. So we are very happy to have you here. Welcome to Madrid. Welcome to this house, which is your house, and many thanks for coming. And now we will start. Thanks again to our friends in Oviedo and in Salamanca. Thanks to you for coming today. Many thanks, George, for being here and for doing this enormous effort coming from Rochester to Madrid. And now I will give the word to Eduardo to organize this part of the meeting, which is the workshop of this afternoon. Eduardo, please.
Thank you. Many thanks, Paco, for your support and for permit that everything of that could happen. And thanks also to my partners and to George for coming. I would like to see if Oviedo and Salamanca hear us very well or not. Ana, Jose, how are you?
Good afternoon, Madrid, and good afternoon, Oviedo. From Salamanca, we are ready. I'm very excited to start the expert meeting with Dr. Herman and all of you. Thank you so much.
Perfect. And Jose, can we hear you?
Yeah, in Oviedo, all perfect, and thank you very much for this invitation.
Okay, everything ready then. As you could see in the agenda, in the program, we have prepared 3 real cases to discuss with Jörg, and if there is anything else to do, Jorge Martinez Solano will start with a case, a recent case that we have here of IC toxicity, checkpoint inhibitors toxicity. So Jorge, please. The rest of the panel can have a seat here in the table.
Well, good afternoon, everybody. My name is Jorge Martinez, and I'm going to present a case of checkpoint inhibitors associated myocarditis. This case is about a 65-year-old man allergic to beta-lactam antibiotics, and it's worth highlighting that he was under regular follow-up visits with cardiology due to an asymptomatic moderate aortic regurgitation. Most important, he had a metastatic sigma adenocarcinoma diagnosed in 2018 and which was under treatment with atezolizumab, which is an ICI therapy. This patient presented to the emergency department complaining of worsening shortness of breath and low-grade fever in the last week. He denied cough, chest pain, or syncope. These were his vital signs at admission, and on physical examination, the patient showed signs of congestive heart failure, and it could be heard a systolic murmur over the left sternal border, according to the previously described aortic valve disease. This was his EKG at admission. He was on AF at 70 beats per minute with narrow QRS and non-specific changes in repolarization. His chest X-ray at admission showing cardiomegaly and prominence of bilateral vascular pulmonary vessels. The blood samples at the emergency department, there weren't leukocytosis or other signs of a systemic inflammatory response, and the rapid influenza diagnosis test was positive. And what should be pointed out is the marked elevation of heart damage indicators. So, reaching to this point, his oncologist requested a cardiological evaluation. This was his echocardiogram, showing biventricular preserved ejection fraction and the moderate aortic regurgitation previously described. Without worsening, this echocardiogram ruled out a worsening of his aortic valve disease. So, now we face a patient with acute decompensating heart failure, low-grade fever, influenza infection, and rising levels of troponin. Which one of the following would be your first diagnosis choice? Endocarditis, myocarditis, and what type? Related to influenza or maybe to ICI therapy? Ischemic heart disease, or acute decompensating heart failure secondary to influenza infection. Maybe the last one is the first that comes to mind, but how could we explain the rise in troponin levels in this patient? And moreover, the patient didn't refer cough or any other respiratory tract infection symptoms. If it had been ischemic heart disease, maybe the patient would have told angina, or the EKG would have shown repolarization changes suggestive of acute coronary syndrome, and that wasn't present. So his oncologist emphasized that the patient has recently started a treatment with atezolizumab once every 3 weeks. Myocarditis associated to ICI therapy is an uncommon disease, but it's been described to be a very severe form of myocarditis, developing ventricular arrhythmias, heart failure, and even sudden cardiac death. Furthermore, early administration of IV steroids has been reported to improve prognosis. So the patient with the clinical suspicion of ICI therapy myocarditis was admitted to the cardiology ward and under cardiac monitoring, and it was started IV steroids. And not only IV steroids, but also diuretics because of the acute decompensating heart failure. Despite the treatment, the patient still complained of persistent dizziness, palpitations, and the levels of heart damage markers kept rising. Moreover, the cardiac monitoring showed frequent runs of non-sustained ventricular tachycardia. So, what's next? What should be done now with this patient? It was requested a coronary angiography, both right and left endomyocardial biopsies, and a cardiac MRI. This was cardiac MRI, with left ventricular preserved ejection fraction, and with the moderate aortic regurgitation previously described. And there were no signs of scar tissue in the late enhancement sequences of late gadolinium enhancement sequences, but there were increased values in T1 and T2 mapping conclusive of acute myocardial inflammation. It was ruled out coronary artery disease, and both endomyocardial biopsies demonstrated necrotic myocytes associated with lymphocytes infiltration. Also, the immunochemistry techniques allowed to better characterization of this mononuclear infiltration, displaying to be CD3 positive and with deposits of IgG antibodies. And also important, of course, polymerase chain reaction for influenza was negative, and for any other viruses. So, reaching to this point, the ICI therapy associated myocarditis diagnosis was confirmed. Despite the treatment, the troponin levels kept rising. The patient was still in heart failure and with non-sustained ventricular tachycardia in cardiac monitoring. He firstly received IV steroids, then it was associated mycophenolic acid, then steroid boluses, and despite this treatment, the clinical situation was still worsening. So it was administered infliximab 4 milligrams per kilogram weekly. The situation wasn't getting better, and the patient was transferred to the acute cardiovascular care unit, where plasmapheresis was performed every other day together with gamma globulin IV infusion, 20 grams for 5 days. This way, finally, the patient was overcoming with relief of heart failure symptoms, with gradually disappearance of non-sustained ventricular tachycardia in the cardiac monitoring. So, and the troponin levels started to lower. So the patient was safely transferred back to the cardiology ward, where he started progressively withdrawing the immunosuppressive drugs until the troponin levels bottomed out, and without relapsing of heart failure symptoms and without any other runs of non-sustained ventricular tachycardia in cardiac monitoring. So, asymptomatic with normal levels of troponin in blood, the patient was discharged from the cardiology ward with 30 milligrams of prednisone daily and low dose of beta blocker. Regretfully, 1 week after the discharge from the cardiology ward, the patient was readmitted to the emergency department complaining of abdominal pain and fever. The troponin levels were normal. The patient hadn't got signs of heart failure, and the urgent CT scan showed bowel obstruction. So, with this diagnosis, he was admitted to the oncology ward, where he died because of perforated peritonitis. So now I would be pleased to open the floor for some questions, for a discussion. And I make up these questions. Can we convincingly state that this patient had an ICI myocarditis? Does the ICI myocarditis fulfill the diagnosis criteria used for other forms of myocarditis? What is the role of cardiac MRI in the diagnosis of ICI myocarditis? Is this disease really so severe to need such aggressive management? Are patients with metastatic cancer and ICI myocarditis candidates for advanced therapies? And for advanced therapies, I'm thinking in admission to acute cardiovascular care unit, plasmapheresis, even temporary circulatory mechanical support. Is the final cause of death of this patient connected to the myocarditis, or maybe is it connected to the aggressive immune suppressive treatment that he received? Thank you very much.
Thank you, Jorge. Excellent presentation. Any questions in the room? First of all, you can think. Salamanca, Oviedo, if you have any question, please, you can interrupt and ask, okay? We will be pleasure to answer all questions from you.
Have they seen similar cases? So at the satellites, have you seen similar cases? Similar if they at the other hospitals have seen something like this.
Salamanca, Oviedo, do you have any similar cases of ICI toxicity with myocarditis or other that you know?
So at the moment we didn't have any case of myocarditis, only suspicious for one patient treated by a pulmonary cancer, but without biopsy or other technical imaging techniques. So we didn't have any until now.
And do you think, Anna, because your oncology service is using that, and also you have a very huge hematology department that in Salamanca probably use those kind of drugs. Do you think it's a problem of diagnosis, or maybe is that it's so rare that it's very difficult to see it?
I think that it's important to monitoring these patients. So now we are going to start a new protocol with evaluating the patients before and during the treatment. So I think that it would be very important to have the results to decide if it's necessary or not monitoring all of the patients or only high-risk patients. But we don't have now a lot of experience in this case.
Jose, do you have any suspicions there in Oviedo, or have you treated some of those cases there?
Here we don't have this kind of patient with this disease, but it's possible that patient stay in the clinical, but we have not detected this patient because the suspicion of this disease is very important for the treatment and the early diagnosis.
What about you, George? Do you have those?
Yeah, we
those
had
patients?
someone. We had a case very similar, and I was thinking we could do a case series of two at least, where at the end it was plasmapheresis, and we also gave IVIG, the same treatment that really made the difference. And the question is obviously why. Just going back from what we heard from the other sides, so I don't know, our colleagues here in hematology, have you encountered it? Have you seen it? No. Are you using immune checkpoint inhibitors?
We use it, but it's less common because we're using relapsed refractory Hodgkin lymphoma, and that's the only indication in hematology, and primary mediastinal lymphoma, and that's all. So it's uncommon to use it.
Yeah, because I asked one of my colleagues, one of my hematology colleagues at Mayo, Stephen Ansel. I don't know if you've heard his name. He led one of the trials with immune checkpoint inhibitors in hematological malignancies. And so it was not reported in that trial, in fact, they've never seen it. So that makes you wonder. I mean, because the way we see it, the case presented like this, we usually see it in solid tumors, isn't that true? And that's something unique. I'm not sure if it relates to the pathophysiology, but it might be a hint. So I think as far as who to monitor and what, I mean, so I think the highest risk group first up are the solid tumors. And then I think it's a phenomenon of how hard do you look. I mean, you're absolutely right. I mean, the first cases presented in the literature, those were the ones that died. I mean, so sort of like a forced mortality review. From what Javid mostly reported, it was 0.1% or so initially, and then they built the registry, and then everyone was feeding in, and then we reached maybe almost 1%. But I think it's really how hard do you look and by which criteria. So I think going back to the question that Jorge posed up front, I mean, is this ICI myocarditis or is it not? I mean, it really depends on the criteria. And so working groups have met in December 2017 in the US. There was a workshop, and then subsequent, one of those goals that came out was to have a definition. And one of the ambitions have been to have something similar to stent thrombosis. Is it probable? Is it possible? Or is it definite? And so that's sort of like the concept. And it was to come out. And I've seen something from Javid Mosley again that he's proposing. But that would be obviously key. And how do we adopt it? Is troponin elevation enough? Because the key, just in this case, for instance, the ejection fraction is normal in echo. I mean, echo is usually not revealing at all. There are even cases, like the case we had, cardiac MRI, we did it twice, was negative. And then we had a PET that showed the inflammation. So it's very problematic just to go by imaging criteria or just to use that constellation. And so there's been a push of using myocardial biopsies. And I'm glad you guys did. So I think based on what we have there, I mean, that would be suggestive. What's your opinion?
Our opinion is the same. The learning, this is a very beautiful case because from the beginning we started to see that something was going wrong with the rise of troponin and the start of the ventricular runs. And that was the key point. Because at the beginning of the admission, the oncologists were the ones who told us we have to put on corticosteroids because it could be a myocarditis. And the cardiologic world was a bit skeptic because he has the influenza. Also, he could have some heart failure because of the respiratory decompensation. It was not really clear. But the truth is that the rise in troponin was not, you could not say why if it's not a primary case of myocardial injury, no? So we had right now 8 suspicion of IC-related myocarditis in the last year, and what we narrowly think is the criteria with not all the rule out of the exploration as we did in this case. We have seen 5 cases probably with myocarditis. The other 3 was an infarction, myocardial infarction with a thrombosis of restenosis of one stent. And the other 2, one was probably toxicity for a previous doxorubicin treatment with ventricular dysfunction. Of course, she was a female, had some troponin at the admission for heart failure, but really not related to the ICI. And the third one was also a cardiomyopathy, but not as clear as this one, probably dilated cardiopathy that has been not diagnosed during her life because she had a left bundle branch block from many years ago diagnosed. So what we have learned is the diagnosis is really difficult. It's really difficult, and the suspicion is the main point, and oncology show us this point.
I would also like to ask Jorge, in order to establish the relationship between the myocarditis and the treatment, it's important also when did the clinic started, because usually myocarditis is associated or starts 30 days more or less after the first dose of the immunocheckpoint. So how many doses of atezolizumab had this patient received before the clinic?
This patient in particular, among the 5 cases of ICI myocarditis we had, is the one who develops the disease later, because he started atezolizumab in October, and he was admitted in February, I think. So
3 or 4 doses.
4 doses.
Mm-hmm. And usually, and sometimes, myocarditis is associated with other immune-related adverse effects. So did he have other adverse effects such as myositis or hepatitis?
Okay. Among the 5 patients, 2 have associated myositis,
Mm-hmm.
and they were diagnosed upon the peripheral skeletal muscle biopsy, not the endomyocardial biopsy. But this patient had no signs of another immune-mediated side effect.
Mm-hmm.
As you have seen, there is a rise in CK, but he was asymptomatic, and we didn't perform a muscular biopsy, but probably some myositis he could also have.
Yeah, the ones who, at least I've been involved in at our institution, they all had symptomatic myositis. It's usually back pain.
Mm-hmm.
I mean, back pain, arm pain, and then diplopia. The ocular muscles are also very, very sensitive. And so that was a common theme. Now, from Tom Nealon's registry that he published in JACC, so from what we quoted, the incidence is going up based on that. The interesting aspect was, as you say, it's usually combination therapy. It's usually early on, but it can occur almost any point in time. And then abezolizumab was the one that, as monotherapy, had the highest risk. And the other aspect was those who ended up with major adverse cardiac events. When you look at clinical parameters, what distinguishes those? How can you tease those out early? So those were the ones with dyspnea and reduced oxygen saturation. So, I mean, if you need oxygen supplementation, patient describing dyspnea, those are the only clinical characteristics early on portraying a more complicated course. And then obviously it's the extent of the troponin elevation.
Mm-hmm. Something very interesting also is why it happened, and the pathophysiology, as you say, is really unclear. Why in solid tumors mainly. Here also we have seen of the 5 cases 2 colon cancer. Mm-hmm. It's in developing in clinical trials, so it's not accepted indication for that. But we have seen 2 of them, and I don't know if there is more data about if the kind of tumor minds for the development of toxicity. I don't know if in that aspect you have information or knowledge.
No, we looked. So the New England Journal of Medicine publication that Javid did, they looked at the tumor, and the tumor, what they found is expressing cardiac proteins. Mm-hmm. I mean, Dasmin, cardiac troponin. There are other reports too that lung cancers express troponin T. So it is conceivable that there are antibodies forming and then cross-reacting. That was the bottom line of this experimental paper that you might likely be aware of from Japan. Mm-hmm. Many years ago, PD-1 knockout mice. So that induces autoantibodies, and cardiac troponin is actually expressed on the surface of the myocytes and serves as a recognition point. So with the IG lining that you showed. So the question is that's what's happening. And then the other thought process is because it's also a stress response in the heart, the PD-1, PD-L1 pathway. So if you have pre-existing conditions where this is upregulated, then the brake is on, not to overreact to that inflammation. So you conceivable, for instance, after an MI. So you would see it, ischemia. So if in that setting you take the brake off with these immune checkpoint inhibitors, I mean, that is obviously very problematic. So some of it might not be as fancy, the cross-reactivity, some of it might be just plain.
Also, they say that normally the myocardium, because when it gets injured, it cannot regenerate. It has in its surface PD-1 and PD-L1 in order to down-regulate the immune response. So when you use checkpoint inhibitors, you like threaten this immunoprotection, and that's why the myocarditis occurs.
Now let me ask our radiation therapist here at the table, because we have one case we encountered was after radiation therapy for an adenocarcinoma of the esophagus, which is close to the heart. You radiate it. So do you think that could be a setup? Radiation therapy that somehow the heart is not fully shielded, we have inflammation, and then we'll give an immune checkpoint inhibitor, or is that inconceivable?
I don't know in this case, but I can, in this treatment with a linear accelerator, the beam energy of the photons, perhaps 6 MU, and with this energy, the rays to the heart, more or less 30 rays, and with these dose don't have any toxicity, I think. But in this case, I don't know exactly the dose to the heart.
There's a question in the public. Javier?
You've been talking about the risk related to pre-existing conditions. This patient had moderate aortic regurgitation. Is moderate valvular disease a risk factor for higher? I mean, we always consider maybe moderate valvular disease, moderate regurgitation is not, nothing is supposed to be wrong in the ventricle, which is probably not right. So how do you deal with moderate valvular disease in the workflow of this particular patients receiving these kinds of drugs? Is it a risk factor? You consider it a predisposing condition, or you think it doesn't play a role?
It's difficult to answer. I mean, we don't have really a series to go by. I mean, that would be the way to do it, right? I mean, to categorize. I was surprised the other day by the courage of our oncologists, let's put it that way. They don't call, they know it, they can handle it, and they start patients with an EF of 30% on immune checkpoint inhibitors. And so there you go. That's definitely a pre-existing condition, I think, is a little concerning. And lo and behold, that patient developed florid heart failure. But did we prove that the patient had myocarditis? No. I mean, she decompensated. And there's this other element of this, what others have described as non-inflammatory cardiomyopathy with immune checkpoint inhibitors. There are also other phenomena, and you alluded to it, right? You can have, we don't really know, because the long-term follow-up, I think, is not there yet. I'm coming from the vascular side to the cardio-oncology world, so I like vascular disease, I like atherosclerosis, and for a long time we've been talking about the T cells involved in atherosclerosis. So that's another question as far as pre-existing coronary artery disease. We tried to look at a series at our institution going off PET scans, FDG PETs. Can we see any signal as far as activity? The resolution and what we could find wasn't good enough, but that would be something. Because what happens to the plaque once you take the brake off? I mean, the T cells, supposedly, if that theory is true, that should become more active. Then other cases we've seen are these pericarditis ones, just to complete the circle of what you can see with immune checkpoint inhibitors. Those were actually the first ones that we received phone calls on from oncology, were those with pericarditis, pericardial effusion, sometimes quite extensive. So that can also be a phenomenon. So it doesn't have to be, it's not as restricted. But among all of these immune checkpoint inhibitor, myocarditis is the most fatal. One of the more recent systematic reviews, you mentioned other immune-related adverse events. If you compare them all, myocarditis is the most fatal. So that's where I think the concern is, and then that's where we tend to get our guns out. In the U.S., you know, right? There are a lot of cowboys, and so they carry their syringes loaded with methylprednisolone, but that was one of your other questions. Is that the right thing to do? When do you pull the trigger? What kind of threshold do you need, and then what kind of potential problems could you end up with? So there we have to, because I don't know, as a cardiologist practicing in the U.S., you tend to lose internal medicine knowledge, and so that's where you come in. As far as someone with rip-roaring influenza, is it dangerous to give 1 gram of methylprednisolone for a couple of days, or not really?
I think that the risk of dying from the potential myocarditis is higher, and therefore maybe you could put the antibiotics or the antiviral treatment plus the corticosteroids. But the more you delay the start of the corticosteroids, the worse the prognosis could be.
Just a quick question. How many cases of pneumonitis have you seen?
Oh, sorry?
Pneumonitis, inflammation of the lungs.
That's more frequent than myocarditis, and it can also be very fatal. We usually need to ask the pneumologist to do a bronchoscopy as soon as possible, and we start corticosteroid treatment even without the result of the fever bronchoscopy.
And how differentiate then shortness of breath, cardiac versus pulmonary, the old battle? Who's the culprit?
If we have any doubt, we normally ask the cardiologists to help us out. But still, when Jorge made a question about how to treat these patients, if they should go to units such as the ICU, because we're talking about metastatic patients who are receiving maybe a second or third line treatment for their tumors, and that we know that they are not going to cure from this tumor, so they will die in maybe months or a few years from the start of treatment. But I think we need to first make a difference on an individual basis. Each patient is different. And also, it's very different to have a patient with complications from the tumor or from the progression of the disease as complications from the treatment. I think we should always treat the toxicity from a treatment. If a patient has a stable disease, even though if it's metastatic, we shouldn't let him die because of toxicity of treatment. So I think these patients, if the tumor is stable, that's important, we should treat them in the ICU if they need the treatment.
The problem is when you don't know how stable is the tumor, because, for example, in this case, we didn't have time enough to see if the tumor was stable or not. But I agree with your position, and probably we have to get used to admit those kind of patients from now on in the ICU and treat with all the guns we have for that toxicities.
Yeah, well, that's a very important point as far as the bigger picture, because at least at our institution in the U.S. in general, I would say, from what you've described, we're talking about a house, the price of a house. That's at stake as far as investing what we do. So one of the recent cases we had in the ICU, elderly lady, lung cancer, started on an immune checkpoint inhibitor, then developed back pain, diplopia, troponin elevation, everything you needed. But we just were up front with her and her family, because we could really see it written on the wall where this was going and what she would like to do and what the family would like to do, and they were not up for going through this. I mean, in the bigger scope, I mean, even if we pull through, because there was no option to resume an immune checkpoint inhibitor-based therapy, and that was the last resort we had. I mean, that's tough. That's really, I mean, really challenging. But is this something, I mean, to do? I mean, if a patient is on the, I mean, as far as the last resort or last regimen that's possible and develops this, right? That's a tough question.
That's very challenging, yes. And also, I was on call when this patient died, and it was very sad because the patient was stable from the myocarditis, but the reason for dying is because he had a bowel obstruction. So it was because of progression of the disease after going through a long treatment for the myocarditis.
If there is no other question in the room, I have a question for Salamanca. Anna, can you hear me?
Yes, we are hearing you.
Anna, I know you come from the imaging, and what would you think about the magnetic resonance of the patient? I asked that because at the very beginning, the magnetic resonance seemed quite normal, even with that high ejection fraction. And if it wouldn't be because of the endomyocardial biopsy, probably we would not be so intensive with the treatment and the corticoids. What do you think?
My opinion is that the tissue characterization with mapping techniques that we have seen in the presentation showed it tissue mapping with tissue times increase more than 65 milliseconds, so it indicates inflammation in myocardium. So the diagnosis it would be very probably with this data.
Esther is here with us, and she know the case because she performed the magnetic resonance, and as she said and transmit us at the beginning, the maps is over there. The T1 and T2 maps were not very expressive. I don't know, Esther, if you want to say something else.
In fact, we had to repeat the MRI. I don't know if you can hear me correctly. In fact, we had to repeat the MRI because the quality of the images in the first place was not very good. So, in fact, I'm pretty convinced that T1 and T2 mapping is the best tool that we have nowadays for the evaluation of this kind of patients. But sometimes it's difficult to kind of state some priorities. So in this patient, which was quite tired, he was not in a very good clinical condition, we performed the CNA imaging, we performed the T2 stereo imaging, also the late enhancement. And in fact, I think we have to change a little bit our priority and perform the mapping in the first place when the patient is not tired. In this way, we can improve the quality of the images. Because I think the problem with that case was that when we reached the T1 and T2 mapping images, the quality was going down. So in fact, we had to repeat the mapping in the following week. In that second MRI, the results were more conclusive.
José, ¿tenéis alguna pregunta en Oviedo? Do you have any question from Oviedo? Have you seen any toxicity related to ICI, not myocarditis, but other, or have you assist any patient with doubts called from oncology or hematology in your hospital?
No, we have not any patient with this type of myocarditis, but another patient with another cardiology problems, we treated conjunctive, but the good relationship between oncologists and cardiologists, but not in this myocarditis type.
Okay. If there is no other question, I think we can... Mariana, please.
I have a question for Dr. Herman. Do you know if there are any experience with tocilizumab for the treatment of this kind of toxicity?
Not really. I mean, you pretty much used all the treatments that are have been described in this case. The only thing was the antithymoglobulin. That might some have some experience with that. Antithymocyglobulin. But other than that, I mean, it's aggressive immunosuppressive therapy, but not what no.
What do you think specifically?
Tocilizumab is an anti-interleukin 6, and it's
for CAR T cell, for instance, we would use it.
It's the first step in the treatment of the toxicity for the inflammation. So it's the first step in the inflammation reaction. So it could have sense, perhaps.
Yeah,
I'm not sure.
No. I mean, we think it might be, but it's costly. And that's alluded to plasmapheresis and IVIG. But we were along the lines to reduce, for one, the levels of the antibody. The problem is has such a long half-life, doesn't it? I mean, once it's in for a while. Mm-hmm. And then to try to remove it and to get to a new steady state and to remove again. But then also with the thought, are there some circulating autoantibodies? So, I mean, because you had a very nice response, we did too. Even though in our patient it took still a very long time till the troponin went to completely normal levels. So it can still linger and it needs this long steroid treatment with a slow taper. But yeah, I mean, mechanistically and what it is, and I'm so intrigued that we don't see, I mean, I haven't heard of the hematological malignancies being associated with more solid tumor. What is it? Mm-hmm.
Okay, if there is no question, Jose, are you ready to present your case from Oviedo?
Good afternoon to Salamanca and Madrid. Could you hear me okay? Could you hear me okay?
Yes, we hear you, Jose, now. Okay. Thank you.
Perfect. First, thanks and congratulations for the meeting, organization. I am José Rosado. I'm not an expert in cardio-oncology. I am a clinical cardiologist, and in my hospital we have not a department specific of cardio-oncology. So the clinical cardiologists care this patient with more or less experience in this field. So the clinical case that I have chosen not is a surprising case, it's a common case, but I think that this whole case is an example to evidence that the importance of multidisciplinary management of this patient, because this is 2-3 years ago case when in our center the relationship between cardiologists and oncologists was very distant. This case was mistakes and delayed diagnosis that is very interesting for this point. The title of the case is Cardiotoxicity and Pulmonary Embolism at the same time. The patient was a woman, 70 years old, allergic to urinary contrast media, and without interest familial history. She has risk factor, hypertension with a correct treatment with valsartan, diabetes with metformin, and dyslipidemia with simvastatin without recent controls. Normal weight and no cardiovascular events previous, normal renal function, and no surgical history. The previous medical decisions documents, and the oncology history starts in February when the patient referred a palpable tumor in upper abdominal quadrant in left breast. She did mammography, ultrasound, and MRI, and the tumor. One moment. Okay. This is the tumor. It's the thickness tumor with minor diameter 4-6 centimeters. So in the ultrasound of axillary nodes, suspicious axillary lymph node, so the patient did tumor biopsy that confirmed ductal invasive breast cancer with immunohistochemical progesterone and estrogen receptors negative, SRC2 positive, and high Ki67 and P53 very positive. Axillary lymph node was positive for malignance, and the oncologist did in this patient a chest abdominal pelvic CT without metastasis. This is the clinical stage, T2MX, but with axillary node positive with PAF and no metastasis. And the breast cancer multidisciplinary team decided neoadjuvant chemotherapy, surgery, or surgical biotherapy, and adjuvant chemotherapy with trastuzumab. The neoadjuvant chemotherapy started in March-May with 4 cycles of cyclophosphamide and liposomal doxorubicin. The oncology chose liposomal doxorubicin because the patient was an old woman with cardiovascular risk factors. And later, the 9 cycles of aceclidacel and trastuzumab intravenous, and later subcutaneous trastuzumab. This is the follow-up of the patient in the neoadjuvant chemotherapy. All the follow-up in this moment were realized for oncologists with analytical, with lab analytical parameters, without cardiac biomarkers, and ECG and MUGA. Previous to start with the chemotherapy, this is the ECG, that is pretty normal. And the ejection fraction was evaluated by MUGA with 56%. She started then with liposomal doxorubicin and cyclophosphamide, and in the first cycle, the patient had a deep venous thrombosis and started with heparin with good evolution. In the May, June, and July follow-up, the control was normal, and ECG and laboratory parameters are normal too. So she started with paclitaxel and trastuzumab in July. August, the oncologist repeat a new MUGA to evaluate the ejection fraction, and it's the same to previous. And in September, the patient was attended for surgery. The surgery is a left mastectomy with the axillary lymph node dissection, confirmed the ductal invasive carcinoma, and the same histopathological findings. and with a 9 positive acellular node with metastasis. So the pathological stage was T2, M2, and M0. The post-surgical therapy was chemotherapy with trastuzumab subcutaneous and radiotherapy in chest, axial and subclavicular node, and Avastin over the scalp. This is the all complete follow-up previous to the surgery and post-surgery. When in October the patient stayed with 6 months with heparin, the oncologist stopped this treatment, and the evolution in October, November, and December was normal without incidence. New MUGA for evaluating again the atrial fascium were realized in December, and a mild decline of atrial fascium, but they continue with trastuzumab. The problem started in January when the patient goes to emergency department for important dyspnea and similar things in her right leg with a new deep venous thrombosis and the tachycardia in the ECG. This is the ECG in emergency department with sinus tachycardia with diffuse alteration in the repolarization. The chest X-ray surprised me because for the suspicion of pulmonary embolies, they have a congestive interstitial edema and a pleural effusion in the interval 6 weeks. This is the laboratory findings and highlight the troponin T is high and NT-proBNP very high with high dimmer and alkalosis respiratory with moderate hypoxemia, and the previous findings in chest X-ray and ECG. The final diagnosis in emergency department was deep venous thrombosis, likely pulmonary embolism with Wells Rule 4. This is the Wells Rules, previous deep venous thrombosis and heart rate and active cancer on clinical signals DVT. So, likely pulmonary embolism. Surprised that in this moment the emergency department doctors don't solicit a CT because the patient was allergic to the ural contrast, but they neither solicited another imaging test, so it's possible that they don't have suspicion another problems. The patient with mild hypoxemia, with no respiratory failure, and hemodynamic stability. Start therapy with tinzaparin again and toracemid for the X-ray congestive, and the patient was hospitalization. 2 weeks later, the oncologist derived the patient to cardiologist, and this is of the first visit to ambulatory cardiology. The last functional was better, no chest pain, and the treatment in this moment is metformin simvastatin, stop valsartan for low blood pressure, and tinzaparin, toracemid, and trastuzumab. The physical examination show a better of pulse, but and a better saturation oxygenation with low blood pressure. mitral systolic murmur intense was detected in physical examinations and minimal alveolar damage. This is the ECG of the patient. In this moment, the single rhythm is better at 70 beats per minute, and the repolarization remains alterated in this ECG. The chest rate is better without congestive symptoms in this moment, and this is the echo. In the echo, the patient was marketed like left ventricle with dysfunction and severe mitral regurgitation. This is the report of the echo in this moment, with moderately dilated left ventricle, cerebral hypokinesis, with atrial fraction 50, mild dilated left ventricle with mild dysfunction, related with the pulmonary embolism, functional severe mitral regurgitation, and no pericardial effusion. The diagnosis in this visit was likely subacute pulmonary embolism, treatment with heparins, heart failure with ejection fraction, 2-class functional dilated myocardiopathy related with toxic mass by chemotherapy, severe functional mitral regurgitation, and low blood pressure for possible diuretic effects. The therapy in this moment started in April and bisoprolol at low dose, and discontinued toracimig and contact with oncologists for stop the trastuzumab. This is the evolution in the first visit to the cardiology. We start in April and bisoprolol and uptitrated to this dose. 1 month later, we realized a new echo with similar findings, and we start spironolactone. And in the July, the clinical of the patient was really better with NIHA 1, 2, and the echo was very near. This is the ECG of the patient in the first visit ambulatory cardiology in July, with normalization of the abnormalities in the previous ECG, and this is the echo in July, with a recovered ejection fraction. Sorry. With a recovered ejection fraction, not mitral regurgitation, and ejection fraction in this moment was 50. This is a complete report of the castrated echocardiography in this moment, no dilated left ventricle, ejection fraction 50, and normalization of parameters of right ventricle. In July, we start empagliflozin in this patient because he's a diabetic with history of previous heart failure, and the evolution was very well with NIHA 1 month later, and the last echo was in January of this year with the same findings. The last ambulatory cardiology visit was in April with NIHA 1, good exercise tolerance, no oncology recurrence, and the medication actually is April, bisoprolol, spironolactone, metformin with empagliflozin, rosuvastatin, and tizaparine. And the lab findings is this one, with a normal LDL and a could duplicate hemoglobin. The conclusion was venous thromboembolic disease are more frequent in this kind of patient. Clinical suspicion and early diagnosis are essential. Doxorubicin and more likely trastuzumab cardiotocity were involved in this case. MUGA will report enangioplasty, but what happened with valvular heart disease, the medication of strain and gastric function, full correct initial cardiology evaluation had present heart failure, and the reversibility of myocardial damage were related with a correct cardiology therapy. But primary prevention hypertension of a woman is indicated in this patient. Cardiology multidisciplinary teams are very necessary to proper manage of this patient. And this is the last slide with a question to expert. Post-embolic phenomenon in oncological patient without recurrence of oncological history, how time continue with heparins, what is your real experience with direct anticoagulants in oncological patient? Should we do transplant echo in more patients, or is it enough with MUGA in some patients? What is this patient? And if the patient recovers the ejection fraction, should we introduce trastuzumab or not? And the last question, what is your experience with glucosurics in diabetic oncological patients? Thank you very much.
Thank you, Jose. It's a very interesting case, and I have here many questions. I don't know if there is any question in the room for Oviedo. Esther, please.
I want to ask a question to Oviedo. Are you still performing MUGA for follow-up of oncological patients, or have you changed your practice in the last years? I find that MUGA is, well, you pointed at the end of the speech, MUGA has the problem of radiation in such patients, and as you point out, it only allows for a little bit late diagnosis.
Jose, have you heard?
Yeah. In my hospital, now the principal test is the echocardio, transthoracic echocardio, but previous 2 years ago, the petition of transthoracic echocardio was dilating the time, so the oncologist relies a lot of MUGA in this moment. But now, in this patient, we do a transthoracic echocardio.
Any other question in the room? Mariana, por
I wanted to know, did you take the Corana score in the moment that the patient was with the thrombosis? I mean, the body mass index or the analytical data, the risk of thrombosis for the patient when she was on treatment, she had indication for prophylaxis or not?
Yeah. Yes. See, in this patient, not until the prophylaxis previous, and the question is if.
Mariana, maybe you can explain a little bit that score that you have mentioned, because actually I don't know if somebody in the room really knows what are you referring to. Also, I didn't know it till you told me. So it's better if you explain why in some patients with hematologic disease or with cancer disease there is specific scores to do primary prevention of thrombosis, and maybe that patient with analytics and the risk factors could fit that high risk thrombosis.
Yes, the Coran score is more used for the oncologists than the hematologists because it's a score specific for oncologists, and it includes data about that categorize the risk of patients for developing thrombosis at the moment of diagnosis of the oncology disease. And include body mass index and parameters of the laboratory. I don't remember because
you just need a CBC.
Yes.
So all the three elements of the CBC.
Yes.
And then it's the type of cancer.
Yes. Yes.
And the BMI.
The type of cancer. So the hematologists have there is a recent score similar to Corona but with another parameters included. That is a Charlie score, and that it identifies well the risk of thrombosis at the moment of diagnosis for lymphoma, for example.
Yeah, so there are several scores now. There was the Portrait study, and they came up with a score. So variations for this, as far as I know, the Corona really is just for the first few months, as far as for what it applies for if you want to go strictly from time of diagnosis. This being said, this, as I understand, you can correct, please, is that's the most vulnerable time, isn't it? So the VTE, I think that might be one point to make. The risk of venous thromboembolism and even arterial thromboembolism is highest within the first few months after diagnosis, and then it declines. Is that right? Mm-hmm. And so it's also higher the more extensive the cancer. And so, I mean, because going back to your point, I mean, who do we start on prophylaxis? I mean, who do you start? I mean, the patients you see, have you ever started anyone on prophylactic low molecular weight heparin?
No, if they are not hospitalized, we usually don't do the prophylaxis.
At least, I mean, for the US guidelines, the only group that really needs to be considered are multiple myeloma patients on immunomodulatory drugs. So they either get aspirin or they get anticoagulation. But it's not otherwise, I mean, in general recommendations, at least in the US, the recommendations can be considered if the Corona score is 3 or higher. And 2 studies published in the New England Journal of Medicine end of last year, right, with the approach of providing anticoagulation if the Corona score is 2, at least 2 or higher. But they were ambivalent, right? Or what was the take home from that?
Yeah, there's really no formal recommendation for prophylaxis today. It's all things to be considered.
And then for recurrences, because I think, so if a cancer patient has a VTE, then they have a 6-fold higher risk to have a recurrence. It's about a 30% chance of having another VTE per year. And so the same score that you applied the Wells risk score, so the same Wells also did an Ottawa recurrence VTE risk score. And it's interesting, so in that, I mean, tumor goes into it, and so lung cancer would increase the risk, but breast cancer would take away from the risk. So, I mean, the interesting aspect here is that we have it in a woman with breast cancer, and these events are occurring. So it is, to a degree, it is surprising.
I have a question for cardiologists. If this patient was not receiving trastuzumab and no other chemotherapy, why was she treated with low-weight molecular heparin all through the way instead of initiating an oral anticoagulant?
Jose, I don't know if you have heard the question. We cannot hear you. Just a moment, we have some technical problems, it seems. In my opinion, if you have to use low molecular heparin, has to be in specific cases that cannot tolerate oral anticoagulation. If there is no routinely chemotherapy, I think coumarin could be a possibility. But with the new direct anticoagulants, I think the most important thing is to evaluate the bleeding risk. If there is no special dangerous metastasis, no thrombopenia or other high-risk hemorrhagic scores, I think direct anticoagulants are the best option and more stable anticoagulation in cancer patients, and I think notification is a contraindication for that, and this is changing a little bit.
So you think that in this patient, the change should have been done from a low molecular weight heparin to athenocumarol or to one of the new oral anticoagulants?
In this patient, athenocumarol no, because she's still on trastuzumab every 24.
No, but the treatment was withheld.
After the you seems after the heart failure, when it's probably a direct anticoagulant. I would did the switch to a direct anticoagulant. But the indication of anticoagulation at that moment was not that high. I mean, just because of the vein thrombosis, probably I wouldn't maintain the anticoagulation if there is no AFib or atrial fibrillation or other. Just because of the, I mean, if you ask if because of the dysfunction of the ventricle, we indicate anticoagulation in those patients, not routinely if they are in sinus rhythm.
Eduardo, I have a comment from Salamanca.
Hola, Pedro. Hi.
Hello, everyone. Of course, we agree with treating these patients with new oral anticoagulants, but we have a problem in our national health system. That is that the government doesn't pay the full doses in patients with pulmonary embolism. It is only contemplated to pay for the treatment in atrial fibrillation. So this is probably the main concern for clinicians not to treat these patients with new oral anticoagulants. And this is an important issue, you know, because the patient should pay around $100 a month for the treatment.
So low molecular weight heparin is covered? It's not necessarily cheaper.
Yes, low molecular weight heparin is covered. Also, coumadin is covered, but new oral anticoagulants are not covered for pulmonary embolism, just for atrial fibrillation.
How strict are the inspectors in Salamanca in that way, Pedro? Do you have really problems of covering in those kind of patients?
Yes, we have problems, and sometimes we have received negatives to cover the treatments just because of pulmonary embolism. So sometimes we are happy because the patient has a little paroxysmal atrial fibrillation, and we can cover the treatment with atrial fibrillation. It's very common in these patients, in fact, here in Salamanca.
Okay. Jose, do you have any comments? Can we hear you now?
Oh, no comments. Thanks.
Is your question answered about the oral anticoagulants? I don't know. Any problem with the connection with Oviedo?
Yeah.
Okay.
I only hear you. Okay. Yeah. No, in our hospital, the problem is the same that the person is previously, no? The coverage of the pain of this patient and the facility to put the oral anticoagulants of the calcium in this patient.
I have a question about the case. I want to congratulate you because the case is a paradigm of the high-risk patient for cardiotoxicity. It's an old woman, over 65 years old, with all risk factors, diabetes, hypertension, also dyslipidemia. And she has received cyclophosphamide, doxorubicin, even if it's liposomal, but doxorubicin, trastuzumab, and radiotherapy. And those four agents and the combination of them, even they are not at the meeting point at the same time, I think is the patient that has not to be passed through our eyes without a routinely review, and this is the kind of high-risk patient that should be in the cardio-oncology consulting. At least if it's not on the cardio-oncology consulting, it should be followed frequently with echocardiogram, in my opinion, not with MUGA, and also checking the electrocardiogram and the symptoms. The first hospital admission, the patient had heart failure and no echo was performed at that moment. So maybe some of the cardiotoxicity could be predicted or diagnosed sooner than it was really done. So the question is, do you routinely search for coronary disease or in this kind of patients that has depression of the ejection fraction with those cardiovascular risk factors?
Yeah, initially we think in the possibility of associated ischemic damage in this patient, but the good evolution with the treatments in the follow-up of this patient with the allelic to your contrast, we don't decide to do in this patient coronariography. But I not in the presentation, but the patient did echo stress in the last year and was normal without ischemic symptoms.
So do you usually check baseline cardiac function? I saw it here with the MUGA. And then do you do every 3 months if someone is on trastuzumab? Do you do it here or you don't?
This patient exactly would meet the high risk criteria that we have say that could benefit from echocardiogram at the base, at the end of the treatment, and 1 year after the treatment, so routinely.
Which high-risk criteria do you use?
For that patient, we use old patient, more than 65, diabetic, and a combination of cardiotoxic treatments.
Because I'm just curious, what's that based on? Do you have a reference?
On the literature, in the last guidelines of the Spanish Society, the risk factors that are proposed to cardiotoxicity is those that we have commented, and in those patients they conclude that a based echocardiogram and a routinely follow-up with local protocols should be performed in those patients.
So what about the 35-year-old with breast cancer who shows up with heart failure and one trastuzumab?
Yes.
But in this specific case, this woman, without any, if she didn't have any risk factors, she would have had an echocardiogram every 3 months, just because of the fact that she was receiving trastuzumab. I mean, here, every woman with trastuzumab has an echocardiogram every 3 months.
No, so I'm a little bit pointy about this just because tomorrow you will see one slide. We looked at our cohort at the clinic and we're wondering, so there is the ASCO. We didn't look at the Spanish, I have to apologize, because my Spanish is not good. I couldn't read it.
But it's in English.
I know. But so we could only look at the ESCO suggestion, which is either low risk or high risk, and high risk is exactly as you say. I mean, it depends on age, certain criteria, or sequential anthracycline, Herceptin. And then we looked at another risk score, and so the results will be revealed tomorrow. You have to see it, but it's not so easy. I mean, that's what I'm trying to get at. I think in clinical practice, it's often, we like to think in those categories, and we like to do it. But in the cardio-oncology world, it's not so easy.
It's not easy, of course. It's quite hard, and Javier, that is seated there, also knows how many echoes are performed to check the left ventricular ejection fraction in those patients. So that's why
I have to say, you're right from the literature that's out there. The Italians, there's first also was Rossi, and so a few years ago, the one that they found were at the extreme risk were the hypertensive elderly women, so hypertension. And that's what we've seen in our clinic. The ones who ran into problems on trastuzumab clinically, that we've before, either escaped the echo and presented them with heart failure or had uncontrolled hypertension. So hypertension is definitely something that sets them apart. From the animal model, as you might have seen, there's this nice Nature Medicine paper. When you knock in mice, when you knock that receptor pathway out, the HER2, or it would be ERB2 in mice, they become very sensitive to afterload increase. So that would be the pendant would be high blood pressure. And then that gets to the point that when you constrict their aorta, that they rapidly decompensate and die, decompensated heart failure. So that combination, so it's extremely important, it seems to be that pathway in that setting. The other elements that increase the risk of the upregulation of the HER2 pathway in the myocardium in humans are myocardial ischemia and anthracycline exposure. And so the surprise to me is with the liposomal doxorubicin. Is that something you commonly use, liposomal? Even in, because people argue, at least in the US, AC therapy, 240 milligrams per meter square is what you end up with doxorubicin, which is below the cutoff that's often used, 250. It's all arbitrary, 250. But so is that common use here?
Well, in this hospital, in particular in breast cancer, we do not use doxorubicin at all, not even liposomal doxorubicin. We have a different chemotherapy regimen, which is not as cardiotoxic. We do use liposomal anthracyclines in breast cancer and also in ovary and endometrium, but really there are no, there's not a dose that you cannot go over. And I really haven't seen any cardiotoxicity from liposomal doxorubicin. Hematologists are more used to using anthracyclines than we are.
We use liposomal doxorubicin in patients with with heart rate, with ejection fraction reduced at the moment of the beginning of the treatment, not as prophylactic in patients with high risk, just in patients with damage. Yes.
And how do you check these high risk patients in your daily work in the Mayo Clinic? Do you have resurveillance of the left ventricular ejection fraction every 3 months, 6 months? Do you use biomarkers? How do you routinely deal with these patients really in a high risk of cardiotoxicity?
Yes, so both have been suggested. The echo with strain. I don't know. Do you use that here too? The strain imaging or no?
Not at all the strain.
So that's been. I mean, it's sort of either that or it's biomarkers, troponins. Now, that came from the European Society of Medical Oncology, ESMO guidelines. I mean, it all depends who's on the panel, right? When you write guidelines, it's only who's there, the person with a voice. and the experience is shared. And just because of what Daniela Cardinale has done in Milano, and then others contributing the strain, so it was either or. And others looking at this seems to work out for anthracycline-based therapies. You can do either or. They're both very good because of the high negative predictive value. The incidence is not still as high in general when you look at the population, so negative predictive values are still usually very good. The positive predictive values are not so good if you have a positive trend. Even if you combine them, it doesn't really get that much better.
But when do you perform the troponin?
So we do the echo with strain. We now do the troponin too, and it's particularly looking in these women. And I took the slide out, but I can bring it back in for the talk tomorrow, because we got now an NIH-funded trial where we're looking at patients, breast cancer patients receiving trastuzumab-based chemotherapy. And really the question is what should be our strategy for surveillance, and then when do we initiate cardiovascular medications? So we called it the tactic trial because we didn't know what the right tactic is. And so one group is that we would just wait and see till the EF drops, just like a case like this, and then we would initiate therapy. The other is we do strain, echo strain, and high-sensitive troponin measurements, and we start carvedilol if one or the other becomes abnormal, and see if that makes a difference in the incidence. And then also the other aspect is reversibility of this. And then the first group will be those who preemptively received it. Just an anecdotal note that when we looked at our breast cancer population and we tried to apply the ESCO risk score, we had over 90% in the high risk group. So they were almost, all of them. And so we said, well, preemptively, this group. And the other element, the other question we tried to address, so the first one is, do we need prevention? Number two is, when do we start it? And number three is, when do we stop it? Because that's the other pertinent point in these. This lady is unique, that's a little different. But let's say you have a 45-year-old, a 50-year-old, with no hypertension history, nothing. And you start her on carvedilol because you've seen the writing on the wall with the echo, and therapy is over, trastuzumab therapy is over, success, echo is normal. What do? Do you stop it then, or do you continue? And so we'll continue the trial for another year, and we look at the patients get re-randomized, and then we look at the differential of the EF. Does that make a difference? Because another interesting trend is, and I'm sure you've seen it, is that multiple registries now, the real-world data, have shown that the incidence of clinical heart failure continues to rise in these patients, even after just trastuzumab. It's highest in those with anthracycline and trastuzumab, but that's sort of, something that was thought to be not possible many years ago. That it would be just, trastuzumab being so benign that, it's just really just limited to the exposure, and it has just this wonderful reversibility. So I'm not so sure, and I'm going to show it as some of the concepts that are contended at present. If that's still so true. So I do think they need to be monitored, and they might need to be monitored longer than we think.
When do you think is the best moment to do the troponin? Just before the cycle?
So
just afterwards? Just at the beginning?
So going back to the old mantra, which was that trastuzumab is really not toxic. It's just, it doesn't really lead to any cardiomyocyte damage, though you can in mice somehow detect troponin elevation with trastuzumab alone, but in humans it was thought not to be possible. But it has been seen. Most of these, the high point is after anthracycline exposure, just before they go on their adjuvant part of the trastuzumab therapy. That's when most of the troponin elevations cluster and are seen. And then later on, it's not as common anymore. So reacting to a troponin, I think, is very time dependent where they are in their journey. Whereas when you look at strain, that there's some studies from Yassal in Canada looking at this very carefully, looking at the biomarkers and the echo with strain. The biomarkers, troponin, if you use CRP, if you use whatever you want to use, didn't really make the difference. But the strain imaging showed about 3 months earlier a significant difference in those who will have a drop. So the biomarkers, I think, you can use on occasion. The most useful use of them in our practice has been what, again, Daniela Cardinale published for trastuzumab cardiotoxicity, which is reversibility. So she found that those who have troponin elevation, either before trastuzumab exposure or right after, because that's when it peaked, those are the ones at highest risk for irreversible cardiomyopathy. And this woman, she fortunately had this, recovery, maybe not fully back to normal where she was, but not every patient has. That's another concern.
Also because it's a late onset of the medication. It's more than 1 year from the cardiotoxic chemotherapy, and we don't know how many months the dysfunction of the ejection fraction was before. No? So it's true that is now one of the questions about what to do with all the medications, enalapril, bisoprolol, spironolactone, now that she has recovered, if we would remove it. I don't have a clear answer for that question. I think Paco wants to say something.
This is a very important point. I think that I would like to know, given their experience, I would like to know the approach of Salamanca in this kind of patients. Pedro, Ana, how do you approach these patients in terms of diagnosis, imaging, biomarkers, and how do you manage the prevention? Who, when, and how long?
Yeah. We usually monitoring the patients with biomarkers, with troponin, and the oncologist or hematologist request an echocardiography before starting cardiotoxicity treatment, and if they show any elevation of troponin during the treatment, they refer the patients to our cardio-oncology unit. But it's very difficult to make all the echocardiograms for the women during the treatment once each 3 months. So we use biomarkers.
In all patients, Anna, do you check the ejection fraction of all patients that are going to receive cardiotoxic treatments?
In breast cancer, in all patients. And in more and more, hematology department is request echocardiograms in most of the patients who are going to receive cardiotoxicity drugs for a lymphoma with or other cancers. So we think that we are making 1,000 echocardiographies every year for oncology and hematology patients.
I would like, I don't know if we can see all the 3 hospitals in the screen, and I would like the people who is standing here to stand up, to raise hands, who would re-challenge trastuzumab in this patient. Who is going to give trastuzumab again to this patient? Jose, we cannot see you.
Yeah, we have a problem with the connection. I hear you perfectly, but you don't see it.
Okay, only 4 people here, Salamanca. How many of you will give trastuzumab again to these patients?
With cardioprotective treatment,
with the treatment
close following.
With the treatment that she is taking right now, with spironolactone, enalapril, bisoprolol.
Yeah.
Only 2, and the others don't know or just don't do it. Okay, I think I agree with George that trastuzumab has not that toxicity itself. You think it has?
No, I mean, like, no, yeah.
We think,
sort
of course.
that's the
But there is
concept.
quite evidence of many cases that the rechallenge of trastuzumab after treatment with the recovery of ejection fraction is quite safe, at least. Of course, surveillance of the ejection fraction has to be kept.
Yeah, just to add to it, the two prevention trials we have with trastuzumab, Manticore, I mean, it's one of the usual cardio-oncology ones where we have 30 against 30 patients, 30 against 30. When this one, it was 30, 30, 30, because they were standard perindopril or bisoprolol, and this bisoprolol was given to this patient. And that trial was negative. There was no prevention of quote-unquote trastuzumab cardiotoxicity. Now, they used our MRI person left, but they used a funky endpoint that was part of the problem for their trial. It was a remodeling index that they used as a primary outcome parameter. There was a trend for maybe, I mean, at least a signal for the beta blocker group, the bisoprolol group. That's why we chose carvedilol for our trial. The other big study done was came from Holland with condensartan, and that was absolutely negative. Didn't make it worse, but it didn't make it better, and so that was a key point. So I think these are important aspects. The trastuzumab cardiotoxicity that we discussed here, the interplay maybe with still liposomal doxorubicin even. The hypertension is a big risk factor. And then for the VTE aspect, so I want to go back, at least, I mean, the US guidelines would say, so DVT or PE, non-cancer patients, DOACs or NOACs, that's sort of like, despite the cost aspects, is sort of the recommendation. And then for the cancer patients, low molecular weight heparin.
But we have evidence today to use the NOACs also.
Yeah, so then they say for 3 months you should continue on the same drug you started, and I mean that's the preferred still. And then you should treat as long as the cancer is active. I mean, you shouldn't really just interrupt, I mean, but you should continue. So I think that's another important point. And thromboembolic events, arterial and venous thromboembolic events, they're the second leading cause of death in ambulatory cancer patients after the malignancy. So I think that adds to the case that was presented. So this topic, we think we know it all. I mean, thrombosis in the cancer patients, but it's extremely important. So it's not an uncommon cause of death.
Javier?
I wanted to ask Jörg about your personal experience. I've heard you've started this tactics trial, but for the individual decision-making of a specific patient, I mean, you look at the data in all trials looking at predicting cardiotoxicity and strain. There is a difference in the groups, but there's a huge overlap, right? And you have the issues of reproducibility, low dependency, scanner dependency of the values, and so on. So, in your opinion, in a large volume of patients in a very, very top quality echo lab as it is in your site, do you really think you can get a specific number of strain values in order to decide go or no go for a specific patient on an individual basis?
Yeah, that's the Achilles heel, isn't it? So we have this discussion in our cardio-onc group. So we're 7 of us. We meet every other month. And there are believers and non-believers in this strain imaging. And so we have one from the nuclear lab, and they would love this MUGA scan, and they argue if the strain exactly this drops by an absolute of 3, what does that really mean in the bigger picture? Others, they're convinced, I mean, it's like you could reproduce this 100 times, exactly the same value if you redid it, and we should just go by it. So there are 2 aspects to this. Number one, is it a true signal or is it not? My personal bias is from the studies that were done in mainly anthracycline-treated patients. If you look carefully at the EF, and if you were able to measure the EF very precisely, you would see the same trend. You would see the same signal in these groups in which is real. The other aspect to this is, what do we do with that information? So if the EF is still normal, and let's say the strain dropped by 15 points or relative dimensions, because I mean the ASE guidelines and the European were weighing in as well, it would be, if it's that level, then they think it's subclinical, chemotherapy-related cardiotoxicity, right? I mean, a relative increase in strain of 15% or more, even if the F is normal, is viewed as subclinical cardiotoxicity. But then you can also at each site, and then to transfer the images for echo core lab to read and to be really confident that what we're doing is right. I mean, it's a balance. A few years ago, I was at a meeting in England, and you know how the British are. We see it right now at play in the politics. So they're very skeptical. They're very, and so there was, and this was an ECHO conference. So even at an ECHO conference in England, there were many raising the same concerns you allude to, as far as going by absolute values, where these values are even, one thing to take into consideration, they're not really totally in a vacuum, right? So there's, you have to factor in the blood pressure. They're not afterload, preload, completely independent. There are a number of elements that need to be taken into consideration. So when we, as cardiologists, or echo lab reports abnormal strain, you get all worried and send the patients to it, and rightly so. But I think someone needs to take a step back and look at the bigger picture. What could have changed this other than just the chemotherapeutic? And then what do we do with that information? So I think at this point, bottom line is we really don't know. And then we need not just one study, but we need several studies to look at this.
Big one.
Mm-hmm.
Yeah. Salamanca, any other questions? Any other questions here in the room? Oviedo, Jose? I think we can continue with the third case. Anna, are you ready to present it?
Yes. Okay, good afternoon again. First of all, I'd like to thank the organizers, Dr. Fernandez Avilés and Dr. Zatarain, for giving me the opportunity to participate in this expert meeting. Prior to my presentation, I'd like to welcome Dr. Herman. It's really great to have you with us, and we are very happy for your personal attendance to this session. Thank you very much. In the next few minutes, I'm going to present a clinical case that shows the complexity of patients who are usually treated in a cardio-oncology unit. I'd like to... Are you hearing me well?
Yes.
Okay. The audio is perfect, but we cannot see the presentation yet. Ahora sí.
Okay, perfect. So I'd like to begin by asking you the following question. What's the prognosis of toxic cardiomyopathy based on currently available scientific evidence? So we have 4 possible answers. The first of them is better than idiopathic-dilated cardiomyopathy. The second one is worse than idiopathic-dilated cardiomyopathy. The third of the answers, there are no differences between both etiologies, or at the present time, we really don't know. This is our patient, a 77-year-old woman with a cardiovascular history. She was treated in 2015 for a diffuse large cell non-Hodgkin lymphoma with cyclophosphamide, doxorubicin, vincristine, and prednisone, and 2 additional cycles of the same scheme with rituximab. In addition, the patient was infected with hepatitis C virus, had a multinodular goiter, and she was successfully treated for a tuberculosis several years ago. In February 2017, the patient was admitted to our hospital because 2 weeks before, she began with shortness of breath on exertion that progressed until minimal efforts, even resting on the day of admission. She also referred orthopnea and nocturnal paroxystic dyspnea in the last 2 nights. No change in diuresis, chest pain, palpitations, or infectious clinic. On physical examination, the patient was tachypneic. Her blood pressure was 118 and 77 millimeters of mercury, and the heart rate 123 beats per minute. She had a high-pitched hollow systolic murmur that was best heard at the apex and radiates to the left external border. Auscultation revealed bilateral crackles. Chest rays saw cardiomegaly, signs of pulmonary venous hypertension grade 2, and left pleural thickening and calcification because of past tuberculosis. In blood analysis, only the elevation of troponin and NT-proBNP with normal acute phase reactance and a slight decrease of the free blood series should be highlighted. An echocardiography was performed at admission and showed a dilated left ventricle with global hypokinesia and severe systolic dysfunction. You may appreciate severe functional mitral regurgitation. In addition, right ventricle was dilated and had moderate systolic dysfunction. So, in summary, our patients who have history of non-Hodgkin lymphoma treated with cardiotoxic drugs in the past was admitted with acute heart failure due to biventricular dilatation and severe left ventricular systolic dysfunction. So what tests would you request to complete the etiologic study? Could I know your opinion about that? Or
Eduardo, any comments, any suggestions?
In that moment and in this patient, probably the computed tomography could say something about the coronary arteries. I don't know if the patient at that moment could be able to tolerate cardiac magnetic resonance. Probably she seems to be quite frailty and maybe not cardiac catheterization at the beginning. Esophageal echocardiography is also a good choice.
Okay, so in this case, we decided to request a cardiac magnetic resonance and a coronary CT to rule out the ischemic etiology of systolic dysfunction. So we have more or less the same opinion. As you could see on the slide, cardiac magnetic resonance confirmed echocardiography findings. Left ventricle was dilated with severe systolic dysfunction. Left ventricle ejection fraction was estimated in 18%. In the case of right ventricle, the dysfunction was quantified as moderate. A study did not show late enhancement of ischemic features, no subendocardial pattern, but the existence of an intramyocardial stria in basal septum. Furthermore, a study of tissue characterization with mapping techniques was carried out. Relaxation times T2 and T2 star were in normal range. However, both native T1 time and extracellular volume were increased. Yeah. Here you can see the study with cardiac tomography. It showed the absence of coronary calcium and the absence of significant stenosis in the epicardial arteries. The patient remained hemodynamically stable. Medical treatment was introduced for heart failure, including beta blockers, but only a low doses due to low heart rates, and antagonists of mineralocorticoid receptors. Angiotensin-converting enzyme inhibitors could not be initiated because of symptomatic hypotension. Hematology department was consulted for presenting a fall in the free hematopoietic series. They ordered a PET-CT scan. This test showed no hypermetabolic loci. Moreover, they indicated external follow-up in hematological clinic. In addition, gastrointestinal department assessed the patient for hepatitis C virus and decided to follow up in outpatient clinic. At the time of discharge, the patient was treated with the drugs you could see on the slide: bisoprolol, aldactone, furosemide, she was scheduled for an early checkup at cardio-oncology clinic 10 days later, and in addition, reviews in hematology and gastrointestinal outpatient clinics were scheduled. Here you may see graphically the follow-up of the patient in the cardio-oncology clinic from the hospital discharge to the present time. The first day that the patient was assessed in the cardio-oncology clinic, she stated discrete clinical improvement from hospital discharge. She was hypotensive with values of 89 and 59 millimeters of mercury, and the ECG showed sinusoidem at 65 beats per minute. Echocardiographic study demonstrated no significant changes with an ejection fraction about 25%. We decided to start angiotensin-converting enzyme inhibitors at low doses with enalapril 2.5 millimeters once a day. The following month, although the patient claimed to have slightly improved and good tolerance to the onset of enalapril, she was still symptomatic for shortness of breath on mild efforts. Blood analysis showed a significant reduction in natriuretic peptides from values greater than 9,000 to 3,000 picograms per milliliter. No major changes in echocardiography. Left ventricle ejection fraction was about 30%, and we decided at that moment to increase the dose of enalapril and to schedule another consultation 2 months later. In May 2017, after 3 months since discharge, the patient was still symptomatic with a left ventricle ejection fraction firmly low. At this point, would you modify medical treatment, increasing diuretic dose, increasing dose of beta blockers, to increase the dose of angiotensin-converting enzyme inhibitors, or starting sacubitril/valsartan? May I have your opinion about that again, Eduardo?
In that point, I really don't know what would I do. Yeah, of course, the right answer is to start sacubitril/valsartan, but being sincere, I don't know if I would start it with 90 millimeters of mercury of high blood pressure. Probably I would stay on the same dose at that moment, and if the patient is doing well, keep on close surveillance, but probably I would be wrong. I don't know, George, if you...
I mean, the ESC guidelines give you some leadway there, right? I mean, as far as you could start it, you could go to Entresto. So there are not many reports on Entresto in cancer patients. That's the thing.
That's it.
I'm just aware of 2 cases reported where they didn't really respond to the traditional medicines, and then were started on Entresto and did well. So,
but this is happening also with other cardiomyopathies.
Right. So I think it might not be as unique to this particular one. But anyway, let's hear what they.
And I don't know if we can hear the opinion of Oviedo. Jose, would you like to answer the question also to Ana?
Will you hear me? Yeah?
Yes, your opinion, Jose, about that question.
Will you hear me?
Yes.
Yes? Okay. I think that I increase those ACE inhibitors in this moment, but possibly of sacubitril/valsartan is a good possibility. And
Okay, Ana, continue, please.
Okay. So, as you imagine, we start sacubitril/valsartan. Following the recommendation of current clinical practice guidelines, our patient had severe systolic dysfunction. Left ventricular ejection fraction was less than 35% and remained symptomatic. Moreover, NT-proBNP levels persisted high, so we considered that the best option was to initiate sacubitril/valsartan. Enalapril was discontinued 36 hours earlier, and diuretic treatment was adjusted. On the other hand, in relation to hepatitis C virus infection diagnosed in 2015, re-evaluation by infectious department revealed a high viral load. Moreover, fibrosis stage was free with fibroscan. So with these results, she started treatment with elvisvir or ruzasvir for 12 weeks. This therapy was successful and the viral load became undetectable. In subsequent cardiological appointments, the patient claimed to be much better. She was able to walk almost 2 kilometers and deny congestive signs. Similarly, echocardiography reported an improvement in left ventricle systolic function. As you can see from the graph, NT-proBNP continued to decline. At this time, we adjusted medical treatment with progressive increase of sacubitril/valsartan, taking into account arterial hypotension with systolic pressure values always lower than 90 millimeters of mercury. In this slide, you can observe the evolution of the ventricular systolic function in the free cardiac magnetic resonance that we have performed on our patient. The first row corresponds to the study carried out during admission, the second row to the study performed 6 months later, and the last row to the most recent one at the end of the last year. In addition, the graph reflects the changes in ejection fraction in both ventricles. The green line is left ventricle ejection fraction. So at severely depressed, function was almost normalized. The index diastolic and systolic volumes of left ventricle are significantly reduced at follow-up. These improvements in heart function correlates first with the improvement of the functional class of the patient. She is now able to walk more than 5 kilometers without dyspnea. And secondly, with a decrease in the serum values of natriuretic peptides and NT-proBNP until its normalization. At present, the patient is asymptomatic, has not required any admission for heart failure. So, in conclusion, our case showed... Uy, lo sé, se me ha... Disculpa. ¿Lo puedes quitar? Oh, hostia. Un segundito de presentación. Sorry.
I don't know if it was the last slide.
We have four more slides, but we are almost at the end.
Don't worry.
So, in conclusion, our case showed a strong beneficial effect of sacubitril/valsartan on reverse remodeling and left ventricular ejection fraction beyond the benefits of concomitant optimal medical treatment. So, let's go back to our initial question: what's the prognosis for toxic cardiomyopathy based on currently available scientific evidence? And if we analyze the scientific evidence on this aspect, we find that it's not very extensive. This is the first paper published in the New England Journal in 2000. The authors evaluate the prognosis of 1,230 patients with cardiomyopathy and group them into categories according to the underlying cause. After a follow-up of 4.4 years, they conclude that doxorubicin therapy has a significantly worse prognosis with a higher mortality rate compared to idiopathic cardiomyopathy, with an adjusted hazard ratio of 3.5 times. This result has been reflected in multiple subsequent papers. However, when we analyze the figures in detail, only 15 patients with toxic cardiomyopathy were included in this study. Moreover, we could not forget that survival among patients with doxorubicin therapy may be conditioned to their primary illness. After this pivotal study, progress has been very limited, and the long-term outcome of toxic cardiomyopathy remains largely an open clinical and research issue. In this other paper, the authors conclude that compared to other forms of cardiomyopathy, toxic cardiomyopathy is associated with a particularly poor prognosis, with a mortality up to 60% in the 2 years after diagnosis. But if we evaluate again the data for the 630 patients included, only one died for heart failure. This particular patient had received high doses of anthracyclines and had several cardiotoxicity risk factors. The last study I want to show you compares outcomes of idiopathic and toxic cardiomyopathies in a single center. They included 555 patients, 67 of them with toxic cardiomyopathy. They find no differences in mortality between the two groups, with a 5-year survival of 86 for toxic cardiomyopathy compared to 88 the idiopathic-related cardiomyopathy. So, despite cancer-related morbidity and mortality and decreased use of cardiac devices in this population. So, with these results, we consider that it's unclear whether the prognosis of cancer therapy-related cardiac dysfunction is comparable with other forms of non-ischemic cardiomyopathies, and the long-term outcome of toxic cardiomyopathy remains an open research topic. With everything I have said, we believe that sacubitril valsartan could be considered a cause for hope in patients, in cardio-oncology patients. So thank you for listening, and now if you have any question, I would be pleased to answer them.
Okay, is there any question in the room or in the panel?
Did you participate in the Paradigm HF trial?
No, we didn't.
But you did, right?
Yep.
And so, because I was sharing with Eduardo that they just published in JACC Heart Failure an analysis based on the etiology and outcome related to the etiology of cardiomyopathy and outcome, and as it always been the case, ischemic is the worst. But I found it interesting there were 30 other etiologies, and among these other etiologies, those were drug-related. And I'm not sure if I couldn't find for sure if this was, for instance, doxorubicin. Would be interesting to see to get some more detail on it. But the outcome was similar to that of dilated cardiomyopathy. And there was no difference in the other, whatever group they're clustered in. But when they stratified based on enalapril or the investigational drug at the time, in that particular group, there was not a benefit. In ischemic and non-ischemic, there was as a general rule, but might have been just a problem of patient numbers as far as statistics. But so I'm not sure.
What we have seen with sacubitril valsartan is that in dilated cardiomyopathy, the reversal remodeling is higher than with normal ICE drugs or RV. And in this setting, I think we have to learn a lot about the special effect of adding sacubitril to that renin and angiotensin-aldosterone inhibition in the body. The problem is that right now, more than those retrospective sub-analysis of published studies, there are not a very active investigation with sacubitril valsartan, neither in cancer, neither in other patients, because of the industry has this molecular quite blocked, and probably we will have to wait a little bit of time to see exactly what is the reason for this benefit.
Just to get with the program for us oncologists, what is or when do you use sacubitril/valsartan? Because we have no knowledge of the drug.
Sacubitril/valsartan was added to the guidelines of heart failure in 2016 as symptomatic patients with optimized medical treatment, and it includes ICI, B blockers, and aldosterone antagonists. Yeah. Once the patient is still symptomatic with class 2 or more, you can add sacubitril/valsartan. So that's the point of the patient with reduced ejection fraction and symptomatic heart failure.
Eduardo, let me show you our experience with sacubitril/valsartan. These are the main data of a retrospective multi-center registry of cancer patients with heart failure treated with sacubitril/valsartan from 6 hospitals with cardio-oncology units. 61 patients were included, 19 of them from our hospital. The median age was 64 years old, and 64% were women, and the most patients had cancer therapy-related cardiac dysfunction, 97%, with a median time from anti-cancer therapy to 40 months. Breast and hematological cancer was the most frequent neoplasm, and 31 of the patients had metastatic disease, and 71 had been treated with anthracyclines. After a median follow-up of 8 months, NT-proBNP levels, functional class, and left ventricular ejection fraction significantly improved, and there were no statistical differences were found in creatinine clearance or potassium serum levels. Moreover, 10 of the patients from our hospital treated with sacubitril/valsartan were studied with cardiac magnetic resonance before and at least after 3 months sacubitril/valsartan treatment, and the table summarized the main findings from baseline to follow-up cardiac magnetic resonance. There was a significantly reduction of left ventricle volumes and a significant improvement of left ventricle ejection fraction. A parallel significant reduction in NT-proBNP levels was also observed. Furthermore, a significant improvement of functional class and no clinical adverse events were detected. So, however, we consider that further size observational studies are required to confirm our initial results.
Our experience, at least what we see in the practice, is perfectly matching with your results. I don't know if Oviedo has any other experience about that.
No, in this field. I have experience in another kinds of dilated cardiomyopathy with good results, but not in cancer patients. And congratulations for the result of this study. This is very interesting study.
And George, what is your experience?
No, we haven't used it as much. Another question I have, or what we encounter is, how do your patients use Google here? Do they? I mean, so because we have those coming in and they say, doctor, I read on Google that valsartan can cause cancer. So have you had that? Have you had patients coming in and say that? Yeah. So what do you tell the patients?
Different ways. I have no patient asking that.
No?
Here, no, in my experience.
They take valsartan in either form.
I've had some patients with that question, but it was not with cancer. And I answered them that it was with Chinese valsartan.
The Chinese valsartan.
It's a sort of a contaminant, or whatever you want to call it. It's not the actual drug, valsartan per se. It's something used in the preparation of the drug as it's dispensed that can cause and has been related to it. So there's been increased awareness and then the hype on the internet as far as not to would take. But I was just curious if you had encountered that. No.
Our patients already have cancers.
They might. That's why they want to maybe sue the company for selling them the drug.
Any other question in the room? Any other question in Salamanca or in Oviedo?
One question I have is so if you look at the beta blockers and you're thinking this patient, had anthracycline exposure and developed cardiomyopathy, do you prefer some beta blockers over others, or is it just class-wide, you use whatever is there? Is there a difference?
The evidence, you know perfectly well that there are not a beta blocker perfectly studied. There were in the cardiotoxicity prevention, there are studies with metoprolol and with nebivolol that assess to see that kind of prevention. Metoprolol never has no study with positive results, and nebivolol and carvedilol seems to be the most specific. I use it with a class effect, and for example, if I have to choose one, my first option should be carvedilol, and I think it's more of the studies are done with that, and also is secure, has demonstrated benefit in normal non-ischemic cardiomyopathy. But if the patient is already taking a B blocker that is accepted in the ventricular dysfunction, I keep on the same B blocker. I don't change. I don't know if you do. You have a
I don't know. What do you do, Anna? Do you have one particular or no?
We usually use carvedilol or nebivolol, but it depends on arterial blood pressure. So it's clear that some beta blockers they are not useful, or also propanolol has bad effects in the patient. So we usually use nebivolol or carvedilol most in patients with heart failure.
Yeah, because we use more, most of the time carvedilol. If we have blood pressure problems, nebivolol. That goes back to the two small randomized trials that were done for cardioprotection with anthracyclines. And then mechanistically, carvedilol with the antioxidant effects, we think it has a role with the anthracycline-related cardiotoxicity. It also, the mitochondrial transition pore and transition pore opening as well, because of the mitochondrial injury related to the anthracycline and how it ties together. There's some, at least experimental data for carvedilol. And then in the animal model, comparing metoprolol, atenolol, carvedilol, metoprolol, atenolol didn't make a difference, just carvedilol. So we're sort of challenging this kind of class effect, if it's really there, and to be trying to really limit it to these two drugs if we can. Mm-hmm.
Hi, Salamanca. I'm Paco. Before finishing and asking again Salamanca, moving from the patient to your entire experience, can you tell us what the Cartier is and how the Cartier is doing? Anna?
Yes. Cartier is a prospective observational study, and we are studying people with more than 65 years with any cancer and with any medical antitumoral treatment, and we have done the intensive monitoring during the treatment and after the treatment, before each cycle, and after finish the treatment every 3 months. And now we are analyzing the results. And the second part is we are going to start Cartier clinical trial that we are going to compare two different preventive strategies. So in one, the oncology or hematology department is going to decide the follow-up of the patients, and in the other arm, we are going to decide what are we going to do with the patients with cardiac imaging and also with cardiac monitoring, and all the patients are going to be evaluated in the cardiology clinic. So with these results, we could set if the intensive cardiac monitoring is useful for the patient or not in terms of morbidity and mortality of them.
Interesting to see the results.
Well, any other question? I think it has been a very interesting meeting. Thank you, Jörg, and all the panel. Well, thank you also, Oviedo, Salamanca. Tomorrow we will continue with the mini symposium at 8:30. We try to be on time because we have tomorrow we will to be very precise with the time and the schedule. And thank you everybody again for this special afternoon. See you.